So refeeding syndrome. Before we start talking about refeeding syndrome, I just want to give you a little pathophysiology about refeeding syndrome. So refeeding syndrome, just in your mind, when you think about refeeding syndrome, what's the thing that comes to your mind right away? What's the electrolyte that, that is responsible for refeeding syndrome, or that is the central in refeeding syndrome pathophysiology? So it's phosphorus. So refeeding syndrome means low phosphate. Okay. What does this mean? Low phosphate. It means what's the energy source of your body is ATP. So essentially, you don't have ATP, and the problem is the low phos. But what triggers refeeding syndrome is not the low phos. Okay. And again, I'm gonna just give you kind of a thought experiment. Okay. So let's say you have time here on the x-axis, and you have insulin levels on the y-axis. Remember how insulin levels, we said, you have a basal insulin levels, right? Let's say that this is patient 1, okay? So, and patient 1 at this point of time, okay, I gave them IV glucose or dextrose. What's gonna happen to the insulin levels? What do you think? They're gonna start rising, right? So insulin levels are gonna go up and then go down and then kind of go down to the baseline. Okay, so this is when you give IV insulin, IV glucose. Okay, so patient 2, again, they have like a basal level of insulin, and here you give them PO glucose. You just give them like a PO tablet of glucose. How do you think the insulin levels will go up? Somebody says higher, but the question is, are they gonna be, how much lag there's gonna be until the insulin levels go up? In minutes, hours? What do you think? Until the glucose gets absorbed, go to the body, and then goes to the beta cells and then gets stimulated. Does that make sense? That makes sense, but that's not really what happens. That the intuition is that that's what happens, is that this is the point at which the insulin levels increase. But really what happens is that the insulin levels increase like this. Notice what happened here. The insulin levels, when you give PO glucose, increased faster and higher than when you give IV glucose. Okay? And again, this kind of goes, it's like a little bit counterintuitive, right? Because why is this happening? Like, why is the insulin levels going higher and faster? Not just higher, faster than when you give IV glucose. And so to understand this, you just need to understand that, usually you have the beta cell, chilling in the pancreas, and the beta cell is what produces insulin. Okay? And what happens is that, inside the blood, you have glucose, and the glucose eventually goes to the cell and then stimulates the insulin release. Okay? Easy. Now, when you give PO glucose, the PO glucose eventually will end up in the blood, right? But before the blood, it will, end up in the GI tract. Right? So this is your PO glucose. So it will go in the GI tract, and then eventually it will, go into the blood. Before it hits the blood, it actually will stimulate the D cell inside the GI tract, and the D cell will produce incretins, and the incretins directly stimulate the beta cell to produce insulin. And what happens is, even before absorption, the insulin levels will start going up just by the mere fact of the presence of glucose inside the D cells. It's almost like an anticipatory response. Okay, that's why if somebody eats and then vomits without completely absorbing the glucose, they will have hypoglycemia because they had the insulin. And this is why when you eat, you get hungrier because even though you just ate, you cause the spike of insulin. If you eat like a simple sugar, you will cause a spike of insulin that will make you hungrier. And this is why they say don't eat simple sugars right away. Okay, so we got this out of the way, all right? So this is important to understand refeeding syndrome, because you have to understand that insulin is an anabolic hormone, which means it's a hormone that first causes building of proteins and muscles and others, and number two, causes consumption of glucose. All right, so it causes glucose to be used, so to enter the cells, and then it increases glycolysis. It will increase, it might inhibit gluconeogenesis a little bit, but essentially it causes the glucose to be used. And eventually when you increase the glucose use, then you wanna use ATP to build other things, right? And so the total net effect of insulin is increase consumption, ATP consumption. That is instantaneous. And increased ATP consumption requires phosphate to be present. Okay? So what really happens is that if you have low phosphate, which means you have low ATP, and you get an insulin surge in the absence of ATP, what's gonna happen? What's gonna happen is that you're gonna shift all the glucose to the cells, and then you're gonna be unable to use the glucose to build anything, and glucose gets trapped intracellularly. And this thing eventually leads to osmotic shifts inside the body. And these osmotic shifts are massive. So you're talking about every cell in your body is taking up the glucose, keeping the glucose inside, and it's not using it. And as a result of this, you end up with essentially edema, anasarca, and then severe electrolyte disturbances. And these things can happen really quick, especially potassium disturbances, and this eventually lead to essentially cardiac arrest. And then, death. And, if you're not careful, you will miss it, because it's easy to do these things. So how do you prevent? You know how to prevent this? Easy. To prevent, give phosphate. Okay? So this is very simple. And who do you give phosphate to? Anybody whose phosphate is low. So the number you're looking for, so a phosphate level of less than 2.2 is risk, increases the risk. So when it's less than 2.2, you're going to replete the phosphate. And the way you replete it, you can either replete it with IV sodium phosphate. You can give 15, 30 grams or something, or IV potassium phosphate. And the important thing is to replete before PO intake, right? So never feed somebody who hasn't been fed for a while with a low phosphate. And these people are usually, ICU patients, people who are transferred from floor, haven't eaten for a while, who came from the ICU, and you never check the phosphate. So it's very important to check the phosphates. Almost daily, you're going to check it, especially if somebody is in the ICU. You're going to be checking it daily, okay? This is very simple, and it's very simple to miss, and all you need is one case to ruin your mood and to miss it. But it's really simple to deal with, at least to prevent. Once it happens, this cascade of events is very fast, and patient might code right away, and you don't know what's happening. Any questions about this one?
Is the demographic usually in patients, as in ICU patients and really sick patients, or is it more like with alcohol withdrawals, people who are transferred from nursing homes and whatsoever?
Yeah, very important question. I mean, usually, surprisingly, people with alcohol use don't usually have this problem. For some reason, the phosphate is not a problem for them. The magnesium is a problem for them. They become hypomagnesiemic. I don't know why. But people who are anorexics, so patient presenting with anorexia or bulimics, they might be at risk. Nursing home patients, again, they're not really at risk. Phosphate is it's very prevalent. You can find it in any food. If you eat any food, you'll have phosphates. In fact, high levels of phosphate is bad, but that's for a different reason. And they're trying to look at phosphate levels in food. But usually it's ICU patients who just came out of the ICU, nobody checked the phosphate level, they haven't been eating in a while, and then they're on the floor, now they need to be fed, and then you put an NG tube and you start feeding. Be careful, okay? And always the dietitian people will follow you, they will find you to tell you, please check the phosphate every day, make sure it's above 2.2 and stuff.